So now we are on live. We are good to go now.
I can start?
Yes, sir.
Yes.
Good evening, doctors. Welcome to this experience sharing program on managing PPH, case studies from labor room. This program is brought to you by Hetero Healthcare. Hetero Healthcare, as you know, has 25 years of excellence, 36 state-of-art manufacturing facilities. Hetero Healthcare has 300 plus products in portfolio and presence in 126 plus countries, has 21,000 employees globally, and is the largest closely held pharmaceutical company in India. Hetero Healthcare is amongst the largest manufacturers of ARV, APIs, and FDFs in the world and has Asia's largest manufacturing facility at Visakhapatnam, Andhra Pradesh. Hetero Healthcare is 360 degrees solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties, pioneering in quality and innovation, and has the distinction of bringing 4 biosimilar products to market within 5 years of initiation. Today's program, experience sharing program in managing PPH, we have got honorable speaker, Dr. Rashmi Kabadi with us. Welcome, Dr. Rashmi. Dr.
Thank you.
Rashmi Kabadi is MBBS MS, consultant gynecologist, obstetrician and gynecologist and laparoscopic surgeon. Madam is assistant professor, KMCRI. Madam is attached to Dr. Kabadi's maternity and nursing home. It deals with high-risk pregnancy care, normal and C-section deliveries, advanced laparoscopic surgeries, and infertility treatment. Madam has about 14 years of experience. With this brief introduction, Madam, we'll start the session.
Thank you for the kind introduction. So, for this topic, I have chosen the junior postgraduates of KMCRI because PPH is one of the important the complications in the third stage of labor, and prompt intervention we can reduce the maternal mortality. And apart from prompt and early intervention, it is preventive also. So what preventive measures we can take in order to prevent the PPH from happening? So that also is an important aspect in preventing morbidity and mortality of the patient. So let us briefly discuss first about a postpartum hemorrhage and then followed by oxytocics, which are used in the management and prevention of postpartum hemorrhage. So, as the definition goes, postpartum hemorrhage means there is a blood loss of equal to or more than 500 ml in vaginal deliveries and more than 1000 ml in C-section deliveries. PPH is one of the leading causes of maternal mortality, not only in India but all over the world, and it can occur in any patient, although some of the patients are at high risk of developing postpartum hemorrhage, like in case of severe anemia, severe preeclampsia, HELLP syndrome, twin gestation, big baby. But nevertheless, PPH can happen to any low risk female who is come with a normal ANC, non high risk patient. She can land up in PPH and morbidity or mortality. So can you change the slide? Yeah. So what is the world scenario and statistics of postpartum hemorrhage? So as I already told you, it is a leading cause of maternal mortality, accounting to around 25 to 35% of maternal mortality all over the world. And MMR in developing countries is 240 per 1 lakh live births, and compared to 16 in developed countries. So the global incidence of PPH is around 4 million a year, and the incidence, the deliveries, and PPH is reported in 2 to 4% after vaginal deliveries and slightly higher in case of C-section. So around 38% of the maternal deaths are due to PPH in India, and 25.7% of the global deaths takes place in India. That is around 2/3 of the patients are attributed to PPH. So India has an unexpectedly higher maternal mortality rate compared to the world. So why does PPH at all occur? As you know, the 4Ts, which are the direct causes of PPH in a woman. These are the tone, thrombin, trauma, and tissue. Tone means whenever there is an atony of the uterus. So this happens in cases where the uterus is not able to contract or retract properly. So these happen in case of prolonged labor, big baby, twin gestation, obstructed labor, failed induction. These cases are more prone for undergoing tonic PPH. Then we have coagulopathies where there is a failure in the clotting system. Failure in the clotting system could be present in the antenatal or intrapartum period, like in cases of severe preeclampsia, gestational thrombocytopenia, or in case of HELP syndrome or liver diseases in pregnancy. That is, we are already aware that there is some kind of thrombin clotting defect in the patient, and we are vigilant in such patients. But there are certain other cases where the thrombin defect can happen de novo after the blood loss. So we know that after certain amount of blood loss, there is a loss of clotting factors as well as platelets with the amount of blood loss. So there is a depletion in the volume of the plasma, and thus the coagulation defect arises because of the blood loss. So such cases can be rapidly deteriorating, and because we are non-vigilant or non about the condition, we might not get immediate blood products at hand and can really increase the morbidity and mortality to a great extent. Then we have the trauma. So trauma could be either in the vaginal delivery or during the C-section. So after vaginal delivery, especially in cases of occipito-posterior presentation, occipito-transverse presentations, or a big baby requiring operative vaginal delivery, in such cases, episiotomy wound extensions, vaginal lacerations are very much common and are expected. So we have to be vigilant during the delivery process. And some patients where there is a rapid progress of labor, like in precipitate labor, and during C-sections, like there could be extension of the lower segment scar laterally leading to uterine artery lacerations, or there could be the placenta previa where there is a continuous the ooze from the lower uterine segment, and any handling can lead to trauma and further bleeding. So these are causes of traumatic PPH. Then the other T, which is the last T, is a tissue where remnant of placenta or membranes inside the uterine cavity will hamper an adequate and optimal uterine contraction and retraction, and also there will be a raw area which is stuck by the tissue, and thus there could be active bleeding from the surface of the tissue which is attached to the placental bed. Next slide, please. So, when a PPH happens, sometimes it is really difficult to the things progress so rapidly that simultaneously, though the intervention is beginning, still we might end up having hemodynamic instability in the patient. But a general rule, as this table is showing, a general rule regarding the amount of blood loss and what clinical manifestation the patient can have depending on the amount of blood loss. So when the PPH is mild, it is said to be having a blood loss of around 500 to 1,500 ml. And there is a moderate PPH when the blood loss is 1,500 to 2,000, and the PPH is said to be severe when the amount of blood loss is more than 2,000 to 3,000 ml, where the percentage of plasma loss is as high as 35 to 45%. So when a patient starts bleeding, obviously the evaluation and the treatment is simultaneously happening. But the assessment is also very important, the assessment of the blood loss. So there are so many methods which are available for assessment of the blood loss. That is the amount of soakage of the drapes. The PPH drapes are available, which helps us to assess the amount of blood loss. But the other indications which indirectly suggest the amount of blood loss are the vitals of the patient and the sensorium of the patient. So in case of mild blood loss of 10 to 15%, there is a little bit of palpitation. Patient complaints of dizziness and dizziness actually and palpitations. And when you examine her, there is a borderline tachycardia in the patient, which is more than 100. As the blood loss goes on increasing, the patient will progressively start having more tachycardia, tachypnea, weakness, sweating, restlessness, then followed by end organ damage signs like oliguria, followed by collapse, altered sensorium, drowsiness, air hunger, and hypotensive shock. Next slide. So how do you approach a PPH? patient when you have already diagnosed that she is having a postpartum hemorrhage. So when postpartum hemorrhage has occurred, the first thing what you have to do is call for help. Call other doctors in the team which are there. Call out the shout out rather than call out. You have to shout out to the sisters, and the assessment of the blood loss, assessment of the type of PPH, okay, and monitoring of the vitals by the other patient. Simultaneously, treatment and evaluation should go on. So all this will have to go on simultaneously. So you assess the tone of the patient, see whether there's any trauma in the vagina or extension of the episiotomy wound, trauma to the cervix, or extension of the laceration into the fornix, or whatever it is. You have to assess the amount of tears and then see if there is any coagulation deficiency or retained products of placenta or the membranes. So you for the coagulation defect, definitely bedside what you can do is which is available at hand is the clot retraction time, the bleeding time, and the clotting time. So these have to be done at the bedside. Simultaneously, you have to send for not only investigations but also cross matching. So you have to send blood for cross matching, and at the same time send blood for CBC, coagulation profile, and if facilities are available, you can also do the what is the total thrombin level in the prothrombin level in the plasma. Next. So now simultaneously you start the treatment also, and supposedly there is an atonic PPH, you give uterotonics. So we know that the active management of the third stage of labor, which is a WHO formulated thing which is called as AMTSL, the usage of oxytocin 10 units IM in the anterolateral aspect of the thigh is given after the delivery of the anterior shoulder. We all know that AMTSL. Now, what is the difference between giving an oxytocin, or rather, what are the advantages and disadvantages of using an oxytocin? Is that oxytocin has to be stored in a cold storage, okay, and the oxytocin is short-acting molecule, though it can be used both IM and IV. When it is given in IV formulation, the onset of action is immediate, that is within about 15 seconds to 30 seconds, but when it is given intramuscularly, it takes uh, about 2 to 3 minutes for the action to begin, and the action lasts for about only 30 minutes, the oxytocin action. And also at the manufacturer level to the receiver level, the cold chain has to be maintained. If the cold chain of oxytocin is not maintained, then the efficacy of oxytocin comes down. So normally, generally, what oxytocin we are using is also a synthetic analog of the natural oxytocin which is present in our body. Now, what if there is another compound which could overcome the disadvantages of oxytocin? So, if there is a compound which is stable at room temperature, if at all there is a compound at which is longer acting compared to oxytocin, and which prevents the usage of further oxytocic agents, and thus reducing the total amount of blood loss in the patient. And thus researchers have found a new molecule, that is carbetocin. Next slide, please. So the carbetocin, which is now widely available in the markets, and the other uterotonics which are there, which are used in which are WHO recommended for prevention of PPH, are ergometrin, symptometrin, and misoprostol. Next slide, please. So now this carbetocin is a analog, synthetic analog of oxytocin. The natural oxytocin which is present in the body is also short acting, and it is secreted, it's a nanopeptide and is secreted by the posterior pituitary, as you all know. Now, the oxytocin which is available in the market is a synthetic analog of the natural oxytocin. Now, carbetocin also is a nanopeptide only, but there are certain structural changes in the molecule which renders it heat stable and also prolongs the half-life of oxytocin. And this new compound is the carbetocin. So Carbetocin, presently, it is approved for prevention of postpartum hemorrhage, and it's an excellent alternative to oxytocin. Next slide. So let us come and try to learn more about the differences between oxytocin and carbetocin. So the oxytocin is also a synthetic hormone secreted by the posterior pituitary. Pharmacokinetically, it is short acting. And how does it act? It acts on the oxytocin receptors. These oxytocin receptors will increase the calcium influx into the cell, which acts on the myosin light chain kinase, leading to myometrial contraction. The half-life of oxytocin is just 1 to 6 minutes, and the uses of oxytocin are not only for prevention and treatment of PPH, but also it can be used for induction of labor and augmentation of labor. Whereas carbetocin, it is a longer acting analog of oxytocin, and it has the onset of action is comparable to oxytocin, and initially it has a sustained contractile action followed by rhythmic contraction and relaxation, which is longer acting compared to oxytocin molecule. It is heat stable, it can be stored in room temperature, and right now it is only approved for prevention of PPH. Next slide. So what is the clinical evidence? So we all know that the WHO champion trial was going on, which was a multi-centric trial where more than 30,000 women were taken into the study, and the efficacy. The objective of the study was to find out the effectiveness or the efficacy of usage of the heat stable carbetocin compared to oxytocin in prevention of PPH following vaginal delivery. And the primary outcome of this champion trial was that the proportion of the woman with bleeding less than 500 ml or the use of additional uterotonic agents is reduced in case of carbetocin usage, and the safety profile and efficacy is comparable to oxytocin. Next. Yeah, so this slide shows the different parameters which was studied in the champion trial. So the amount of blood loss, you can see that more than 500, 14.5, 14.4, which is more or less same. The blood loss more than 1000 ml, we have the efficacy is 1.5, slightly higher in carbetocin group compared to oxytocin. And the adverse events, and the safety profile is more or less same in both carbetocin and oxytocin. So this suggests that the carbetocin is effective modality and a very non-inferior alternative to oxytocin compared to for the prevention of PPH. Next slide, please. So what does the Cochrane review say? The Cochrane review, again, the data from 11 studies shows that for women who undergo cesarean section, carbetocin resulted in a statistically significant reduction in the need for therapeutic uterotonics. That is, it could be in the form of carboprost or misoprostol compared to oxytocin. Also, carbetocin associated with less blood loss compared to symptometrin in the prevention of PPH for women who have vaginal deliveries, and is associated with significantly fewer adverse effects. So the adverse effects of oxytocin when they are used in higher doses is hypotension, and it can cause water intoxicity, which is not found in case of carbetocin. So what are the guidelines? In the prevention of PPH, WHO, SOGC Canada, this is the New Zealand, the FIGO, all recommend carbetocin as one of the modalities which is non-inferior to oxytocin for the prevention of PPH. So what is our experience? In fact, it's everybody's experience here in KIMS. We have been using carbetocin since past 1.5 to 2 years. And what our experience also shows, one of our postgraduate is also doing a study for assessing the amount of blood loss and the prevention of PPH, comparative study between carbetocin and oxytocin. And the initial data also suggests that it is superior compared to oxytocin, according to our KMC data. And can we go for the next slide?
Yeah, in this study that madam you are doing,
Yeah,
I mean,
it's
you are
going
using,
on.
yes, You're doing a,
Yes.
I mean, in case of vaginal deliveries or even in case of cesarean section?
Both we are trying.
Both. And the
Yes, yes.
route that you are using is IV or IM?
I am.
IM in both the cases.
Yes,
But
yes, yes.
overall, how I mean, how you use it? You use it commonly IV or use commonly
We
IM?
are our we are using it IV or IM. In my private, I use it as a IV
IV
dosage.
route, yeah.
IV dosage, yes.
And your experience has been good, like it acts fast
Yes, it
and
is. It
without any
is.
adverse
Yes,
effects.
yes, yes, yes.
Now coming to a few questions. Now this, what is the benefit of using carbetocin as first line drug to prevent PPH?
So as I already highlighted in my talk,
Yeah.
that the benefit is that it is long acting. So oxytocin being a short acting drug, what will happen is the patient needs continuous vigilance and repetition of dosing in case of oxytocin usage. But with carbetocin, we can safely uh, what you say drug free interval is higher because of the long acting drug. The duration of action is more, and the golden hour of pph, that is the fourth stage of labor, that is 1 hour post delivery, is safely crossed
Okay.
by the usage of carbetocin. So that is one advantage. And the second thing is there are many peripheral places, and even in our institute, what we have found out is that the sisters, what they used to do some few years back, they used to load oxytocin once the patient is in the second stage of labor.
Oh,
Before that only, they used to load
uh-huh.
it and keep it in the delivery tray. So what would happen? The
Stability.
efficacy of the drug would be lost.
Yes, yes, yes.
That's why the chances of PPH is high. So maintenance of cold chain is very, very important at
Absolutely.
the receiver end, at the transportation, and at the manufacturing. So in place like India, where transport so many glitches in
Yeah,
transportation,
yeah,
cold
yeah.
storage, so it has the efficacy itself is questionable. What we are receiving at the receiver end, whether the cold chain was maintained or no, we are really it's questionable. So in that perspective, carbetocin definitely has an advantage.
You'll agree, madam, even in big cities, the power outage is quite common these days.
Quite common.
Yeah. And so the best thing is to use carbetocin as a first line in every delivery for every patient. That's the best thing. We try to protect and prevent the worst because finally
Yes,
life is at stake.
yes.
I mean, as you have already said, that there are some patients where we can anticipate PPH. Apart from anemia, which is very common and possibly one of the most common cause and precipitating factor in PPH, other factors which can precipitate a PPH.
Yeah, definitely. As I already told,
Yes.
the prolonged labor, prolonged second stage of labor, and in case of big baby, twin gestations, polyhydramnios, and occipito-posterior position, cervical
Anything? Yes.
dystocia,
Anything which
prolonged
can.
induction, prolonged induction,
Okay.
prolonged induction to delivery interval, and in cases where there is severe preeclampsia, thrombocytopenia, HELP
Okay.
syndrome, liver diseases in pregnancy, all these are conditions where
Risk
even
factors.
chorioamnitis, PROM, all these are at increased risk of developing PPH.
Even gestational diabetes could be one of them, madam.
Yes, gestational diabetes also, because
Could
of
be
the
one of them.
placentomegaly,
Yeah.
the bed of the placenta is very huge, so that
Yeah.
also could impose a risk for developing
Correct.
PPH in such
Correct.
women, and
But like,
macrosomia also.
and
Macrosomia, polyhydramnios associated with
fibroids for the fibroids
diabetes.
one. Yeah.
Presence of fibroids,
Yeah.
increased age of the patient also.
Your experience, madam, in case of RH negative mothers.
I personally don't have any experience regarding
Okay.
this, but we need to see what
Yeah,
studies,
yeah.
how the studies are.
Now, generally, we know that doctors use oxytocin for labor induction. In
Yes.
such scenario, which is very common, can a
Mm.
doctor use carbetocin for prevention of PPH?
Yes, it can be used.
It can be used.
It can
Oxytocin
be used.
duration of effect is very short in any case.
Short, short,
Yeah.
yes.
And by the way, coming to oxytocin, have you seen any time ADH related adverse effects with oxytocin?
No, we haven't seen, but hypotension we have seen. We have
Yeah,
noted
yeah.
hypotension in patients when they are given high doses of oxytocin, fast infusion,
Okay.
especially in a hurry to manage a PPH. Already the patient is losing volume,
Yes,
and
yes.
at the same time we are giving high volumes. And even during C-section, our anesthetist usually they comment that after giving oxytocin, there is a slight aggravation of the spinal induced hypotension. There is a
Oh,
slight aggravation of the
yeah.
spinal induced hypotension. That is what our anesthetist have
Such
comment
adverse
sometimes.
effect, such adverse effect you have not seen with
But
carbetocin.
no, no.
Good. Now you use IV route in your private practice,
IV,
otherwise IM route.
IV,
Any
yes.
specific place for IM or IV?
IM, it can be either given in gluteal region or anterior aspect of the
No,
thigh.
no. Any specific place, in which patients will prefer IM or which patients will prefer IV?
Nothing like that.
Nothing like that. So if you have a help anesthetist or you will prefer IV maybe, or
Yes.
otherwise
Oh,
IM.
yeah. Yeah, definitely. Yes.
And this could be very important, especially in the periphery where we may not have additional help and doctors, use of IV would definitely,
IV route, correct.
yes. And you already answered this. It's well tolerated
Yes.
in your practice. You have not seen any adverse effect.
Yes.
If a patient
And
sometimes,
one more thing, what is the other advantage? What I would like to just
yes,
comment is that whenever a patient is requiring additional oxytocics in the form of carboprost or
huh,
misoprostol,
huh,
we commonly come across the side effects of the carboprost and misoprostol. That is, as soon as carboprost is given, patient will have loose stools or vomiting.
yeah,
All most of the patients are having loose stools and vomiting, and when we give high doses of misoprostol either sublingually or per rectally, they will have shivering and hyperthermia.
correct, correct,
So
correct,
they will develop fever and they will develop chills. Sometimes it helps in it causes misguiding, or it masks the infection, or sometimes can be wrongly considered as infective cause for fever. So these conditions can be prevented because the usage of additional oxytocin will be reduced by using carbetocin. So the
carbetocin.
adverse effects in the patient due to other oxytocics, which so commonly happen in clinical practice, can be avoided by usage of carbetocin.
Plus that prostaglandin related side effect could also be,
Exactly. Yeah.
asthmatics and other places.
Yes, yes. Asthmatics, it is
Yes,
contraindicated,
yes, yes,
carbetocin.
yes. You have already answered disadvantages, or in fact, you
Yeah,
just answered
yeah.
this. Should it be kept as a reserve drug or the first line?
Uh, yeah, it is in par with oxytocin.
Correct.
So definitely, considering the advantages, other advantages, though the cost is initially higher, but overall, what logically we can say is that if we prevent PPH,
Oh, yeah.
then the chances of blood transfusion, the chances of increased morbidity, increased
Correct.
hospital stay, all
Correct.
that will be
Correct.
reduced.
Correct.
So
The
if we logically think, then carbetocin could be a first choice.
the cost of PPH itself could be alarmingly high.
Could be very high,
Yeah.
including the life of the
Yes.
patient.
And it was a wonderful session, and your take-home message over overall experience for the audience.
Of course, the take-home message is that because carbetocin is heat stable, it can be stored in any center without the availability of cold chain facility, and because of the longer acting, the half-life of carbetocin, it is a equally efficacious method to prevent PPH in the active management of third stage of labor.
It was lovely session, madam, sharing your experience, and it gives the doctors who have attended a lot of confidence. Although there are many papers on this, our own doctors' experience always helps the doctors, give them confidence. And it's lovely that to note that you are doing a clinical study to have more insights into the product. Lovely, madam. It
Yes.
was a lovely session. Thank you so much for this. And I thank all the doctors who attended this, who could take time from their busy schedule and attend this. Thank you, marketing and sales team of Heathrow, and thank you, IT team, for super coordination. Thank you so much, and madam, wish you a very pleasant evening. You can sign off,
Thank
madam.
you.
Thank you. Thank you
Thank
once.
you. Thank you. I thank all the postgraduates for attending the session.
Thank you. I'm sure they have
And I
benefited,
thank
madam.
the team Hetero also.
Thank you, madam.
Definitely.
Thank you.
Yes.
Thank you.
Thank you. Thank you.
Yeah.
Thank you.
Yeah, thank you so much, ma'am,
Yes.
for accepting this invitation to share your experience.